Thank you, Dr. Carter, for your presentation to the National Press Fellows next door. Could you share with us some of the latest stats on TB infection worldwide and what you think is the most important fact about that?
Okay. Well, I think we always have to remember whether we're talking about TB infection and TB disease. We still estimate that 1/3 of the world's population is TB infected, but because there are not tests applied globally for TB infection, we really don't know the exact pool of infected that we have in the world today.
You mentioned a link between diabetes and TB today. That sounds very interesting. Can you elaborate a little bit on what you think the future of that is?
Mm-hmm. It turns out that we've talked about the last decade about HIV being the immunosuppressive driver for the TB epidemic. And that is because if you're TB infected and HIV infected, your risk of developing TB disease is increased by a factor of 10-fold. Well, it turns out that we actually realize now that diabetes is a relatively immunosuppressive disease. And so if you are TB infected and develop diabetes, your risk of developing TB disease increases to 30% over a lifetime as opposed to 10% over a lifetime. Now, if you begin to look at what public health epidemics are in the world today, obesity and diabetes is our next major public health epidemic. Placing those epidemics in countries where TB infection is common is actually going to result in the next driver of TB incidence over the next decade. So even here at the Union Conference, I think what you're going to see are tremendous parallels being recommended in diabetes care of what we've been doing in HIV care for the last decade. Diabetics in TB countries, in TB high incidence countries, should be screened for TB, and TB patients are going to be screened for diabetes. This is a parallel to what we were doing for the last decade in countries where HIV and TB were coexisting.
And what nations do you think might be most at risk for that next frontier between diabetes and tuberculosis?
I think we clearly are beginning to see both of those problems in China and in India and that sub-Indian continent. So I think those are the places where we really need to put efforts in healthcare strengthening, bringing together the public health care of TB and what has always been the more individual care of diabetes.
You watch trends in TB across the world all the time. For our journalists, what do you think is the most interesting takeaway that you have seen in your recent research?
That one's harder. I have to think of that one for a minute. I do think for the general public, this knowledge that TB and diabetes are linked. I think also the increasing link between TB and tobacco use. I think that is another sort of unrecognized intersecting epidemics. We've known about the intersection of HIV and TB for a long time. I think the real issue right now is this diabetes and TB, and then it's going to be tobacco and TB.
And just one last question. How has the focus on Ebola affected your work on TB?
I think we have a real opportunity in looking at why Ebola came out of West Africa. The issue was the weakness of healthcare and the healthcare systems for those countries. This has direct implications on all healthcare, but particularly I think also TB. What we really need to do to improve global health is to improve access to care and to strengthen healthcare systems globally. And I hope that we are going to be able to walk away from the Ebola epidemic in West Africa with that clear message. A strong healthcare system, pre-existing, would have taken care of this issue, and it would not be a global issue now.
Well, thank you, Dr. Carter.
Thanks.